Good afternoon, sir. Mrs. AD, a 39-year-old female resident of Kangra, Himachal Pradesh, educated till class 5 and farmer by occupation, presented to our OPD with yellowish discoloration of eyes of 3 weeks duration. She was apparently well weeks back when she noticed yellowish discoloration of her eyes on 1st of April 2026. uh, the discoloration was gradually progressive, and after a few days, she had associated pruritus all over the body, which was more in the night, and the yellowish discoloration was also associated with high colored urine and clay colored stools. There is no history of variation in intensity of jaundice. She gives history of unquantified loss of weight, but she does not give history of loss of appetite. She does not give history of pain in abdomen or history of fever. There is no history of nausea, vomiting, any abdominal distension or awareness of any lump. She does not give history of blackish or silver colored stools. There is no history of loss of shortness of breath or any seizures. Uh, she presented to a local hospital for these complaints, and she was evaluated and she was referred to us. She has history of cholecystectomy in September 2025 at Palampur, Himachal Pradesh, with a history of 1 week old pain abdomen in the right upper quadrant when she was diagnosed with cholelithiasis, and she underwent laparoscopic cholecystectomy. However, we do not have any documents available. There was no histopathological report provided to the patient, but as per the patient, perioperative period was uneventful. She does not have any comorbidities. There is no history of allergies, blood transfusion, or prolonged drug intake. She consumes mixed diet. There are no addictions. Uh, although she has pruritus at increased pruritus at night, but at present it is not affecting her sleep wake cycle at present, and she has got normal bowel and bladder habits. There is no history of malignancy in families. So this is my history.
You can summarize.
Sir, 39-year-old female, farmer by occupation, presented with history of jaundice of 3 weeks duration, which was associated with pruritus, uh, clay-colored stool, and high-colored urine. There was no history suggestive of cholangitis. There is history of unquantified weight loss, but there is no history of loss of appetite. And there is no history suggestive of chronic liver disease. With a history of cholecystectomy in September 2025 for cholelithiasis.
What is your diagnosis now?
So the patient is suffering from extrahepatic, she is suffering from obstructive jaundice, and she is status post laparoscopic cholecystectomy. So I will make my differential diagnosis, sir. Sir, because the patient is having a history of obstructive jaundice of 3 weeks duration, and she does not have pain.
No, no,
And
no. Please, rule number one, okay. Do not explain the reason for diagnosis when you ask the diagnosis.
sir,
Please tell the diagnosis or differential diagnosis, because you might be thinking that the listeners will be biased first. Let us bias the listener or examiner, then you give the result. That's not going to work. Okay, that's not the way to do it. Please ensure that you're answering the question very clearly, only to that. Okay, if you ask the differential diagram, only tell that. Okay, the point of examination, very important role is, do not say more than what is required, because that may land you in trouble. For example, you started describing something, there is a mistake happened, it will be unnecessarily dragged. The question was, what is the diagnosis? What is the differential diagnosis? Just spell it out and stop there. Then you wait for the discussion to tell. Yeah.
Yes. Sir, differential diagnosis, periampullary carcinoma, uh, benign biliary stricture, uh, cholangiocarcinoma. Uh, there can be carcinoma gallbladder, recurrence, and carcinoma head of the pancreas.
So when you get a obstructive jaundice, first thing is whether it is, what is the type of jaundice, point number one. Point number two, what is the broad etiology, benign malignancy. Point number three, what are the reasons for this benign and malignant obstructive jaundice? So three component fulfilling is very important. That is point number one. Now, if you have a differential diagnosis for obstructive jaundice, please tell that. If you have a differential diagnosis of etiology, common etiology, you think it is benign, please tell that. Okay. So here you have summarized a mix-up of etiologies. So some of them are benign, some of them are malignancy. And when you say that some order need to be followed, so when you say that, we understand by default that it is your first, second, third, fourth differential diagnosis. And please don't ask the discussant or examiner to rearrange it. It's a bad idea. So when you tell biliary stricture as a diagnosis, little bit third or for second, we'll assume that that is your priority before the carcinoma gallbladder, because that is how it works. If you want to reframe, please reframe again and spell out the diagnosis and differential diagnosis.
Sir, periampullary carcinoma, uh,
So
cholangiocarcinoma.
it is an obstructive jaundice, is it correct?
Yes.
Are you considering benign as well as malignancy?
Yes, sir.
Now you please list your differential diagnosis.
Sir, periampullary carcinoma, uh, cholangiocarcinoma, uh, benign biliary stricture, carcinoma gallbladder, and my last differential will be carcinoma head of the pancreas.
So two questions you yourself made us to ask. Cholangiocarcinoma, according to me, is part of periampullary carcinoma, because you mentioned cholangiocarcinoma, and carcinoma pancreas is also part of periampullary carcinoma, according to me. So please answer that.
Yes, sir.
So what is your answer? Because you told periampullary carcinoma, you also told cholangiocarcinoma, you also told carcinoma pancreas.
Yes, sir. Sir, my differential
Can the
will be,
cholangio
sorry, sir.
can the cholangios be other than periampullary? You mean to
Yes,
say
sir.
you are
If
including some
if
other?
they are higher up, for example, if Klatskin tumor will not be a periampullary carcinoma, or intrahepatic cholangios will not be periampullary carcinoma.
So your cholangiocarcinoma means what? Any specific type?
Sir, because I was implying that mid or upper cholangiocarcinoma, sir.
No, nothing
Klatskin
is
tumor.
implied. Please be very clear. What you told
Yes,
only will assume. There is nothing
right.
implied in a presentation.
Yes.
Please don't ask the listener, discussant, examiner to go for his imagination. That will be too dangerous. Okay.
Yes.
When you tell that a cholangiocarcinoma, how we are going to assume that it is hilar cholangiocarcinoma?
True, sir.
We are not going to assume. So whatever you are you please imagine that whatever you are saying, we are going to write in a paper, and you reread it, there will be problem, no? So don't prompt us to ask leading questions, because leading questions won't help you at all. Okay. So please reframe your questions, answers again. What is your differential diagnosis? We are going to write in paper exactly what you are telling. Please tell the differential diagnosis.
So my differential diagnosis will be periampullary carcinoma, hilar cholangiocarcinoma, benign biliary stricture, carcinoma gallbladder.
So carcinoma pancreas is not there, or are you including in the periampullary carcinoma?
Sir, that is already included in periampullary carcinoma.
Yeah, Dr. Ashish, Dr. Kunal, please go ahead. Yeah.
So,
First,
yeah,
yeah.
please.
So you have placed this in sequence, or is this a haphazard
No, sir, this is in
different
sequence.
in sequence?
Yes, sir.
So basically, you are saying that in a young patient with a short history, uh, in a young patient with 6 months old history of cholecystectomy with a short history of obstructive jaundice without cholangitis.
Yes, sir.
So in this, you are keeping your periampullary carcinoma as your first diagnosis,
Yes, sir.
hilar cholangio second,
Yes, sir.
benign biliary stricture third,
Yes, sir.
and fourth was
Carcinoma gallbladders.
okay, carcinoma gallbladder. That means missed carcinoma gallbladder.
Yes, yes.
So can you explain why you have kept this all these four in this sequence?
Sir, I have kept periampullary carcinoma first because the patient is having obstructive jaundice without features of cholangitis, and she has a very brief history and she does not have any pain. So, therefore, I kept periampullary carcinoma as my first diagnosis. Since hilar cholangios will also not cause pain and they will be associated with jaundice. Therefore, I kept it as second diagnosis. Benign biliary stricture after 8 months, the first time presenting is unusual, but not impossible because there
So
can be.
one point, I'll interrupt you. See, you are told it is obstructive jaundice. So please don't explain why it is obstructive jaundice in when you are explaining differential diagnosis. You got it?
Yes, sir.
Because that point you already used to explain obstructive jaundice. If you want to discuss about obstructive jaundice, we are eager to know what is the difference between obstructive jaundice between your first differential diagnosis, second differential diagnosis, and if and only if you have a point to mention about obstructive jaundice. But your first explanation was not satisfactory because the question was why it is periampullary carcinoma. Your answer was short duration of obstructive jaundice. Immediately we'll assume that the other differential diagnosis will have a long duration. This is the problem going to happen. Okay. Because of short duration, you told it is periampullary carcinoma. So we are going to assume that carcinoma gallbladder has a long duration. This is the problem. So better not to, if you already explained obstructive jaundice, don't explain that. Now the question is why it is periampullary carcinoma? Why did you put it as first diagnosis? Okay. Now you please tell the specifics of obstructive jaundice in that if you have any, or any other feature you find in clinical discussion, only that point you use. Okay. So please explain why it is periampullary carcinoma. Back to the original question.
Sir, painless progressive jaundice of 3 weeks duration associated with unquantified weight loss and no associated prodromal features and no fever, no pain. Yes, sir.
Can't it be CBD stone?
Sir, could be choledocholithiasis, but would have caused pain, fever,
Not
cholangitis.
necessarily. Not necessarily. So first of all, like probably you should differentiate it as benign or malignant. Then some examiner, suppose he asks, like, can you in malignancy describe which area it can be involved in? Then you might like give some explanations and come to some conclusion if possible. Otherwise, usually it is not possible. It is based on many other assumptions like what is the age, what is the uh, area from where patient comes to, what is the probability of uh, these patients maximum, what is the jaundice, and what are the most important diagnosis, common diagnoses in that area region. So most likely in your with your history and presentation, it looks like you are telling that this is most likely a malignant jaundice,
Yes.
but you cannot differentiate benign ones as well.
Sir, benign jaundice would have sudden onset with cholangitis, which is a more common presentation. And
Benign jaundice, is it always necessary to have cholangitis?
no, no, sir. But what I was implying was because it is benign, the obstruction is usually incomplete, and therefore the chances of infection are more. Here, because she doesn't have fever, that's why I thought that malignant cause could be more probable.
Okay, so okay. Sir, anything else you want to ask, or we can move forward?
You said that you have kept it as first diagnosis. One of the reasons is loss of weight. Yeah, unexplained loss of weight.
Yes.
So, how common is it in periampullary carcinoma, that too with a very short history, to have loss of weight to conclude it to be a periampullary?
Sorry, sir, I am not aware of this.
No, you kept the differential based on this finding.
Yes, sir, malignancies are associated with loss of weight because of hypermetabolic state.
So, I agree to your analogy. So, by that means, will loss of weight be more significant in carcinoma gallbladder in this case or periampullary?
Carcinoma gallbladders.
Then why you have kept carcinoma gallbladder as last and periampullary as first?
Sir, carcinoma gallbladder is a very aggressive disease, and patient has undergone surgery in September last year, and she first noticed jaundice after almost 8 months. Therefore, I thought that this would be possible, but slightly less probable because it's an aggressive disease. By now, she should have had a full-fledged disease had there been a recurrence. That's why I kept it slightly lower, sir.
8 months itself is very aggressive.
Yes.
Have you tried to see what was the post-operative course that time? And could you get some information about intraoperative findings? How was the gallbladder that time? Just to conclude, just to say like it was malignancy or not, if available. Have you tried to like inquire about?
Sir, I tried to inquire about this with the patient, but the patient is not able to produce any documents, and nor do they have any address or phone number of the uh, center from where they got it operated from. So therefore, we could not verify. But she says that she was discharged on the next day, and she was asymptomatic till 1st of April 2026.
Okay, it is an obstructive jaundice, most likely. Although you cannot rule out a benign pathology, but most likely a malignant one. So how will you proceed then? Like now, do you have like any examination
Yes, sir.
findings?
Sir, my patient was examined in sitting and lying position in a well lit room. Her height is 162 centimeters, her weight is 50 kilograms, and BMI is 19.05 kilograms per meter square. Her ECOG performance status is 0, and her uh, vital parameters were normal, and she had icterus, but there was no pallor, and there was no pedal edema or lymphadenopathy. Her systemic examination was normal. Her on abdominal examination, her umbilicus is central, inverted, and previous laparoscopic cholecystemic scars are present. They are well healed. There are no dilated veins, scars, sinuses, or all quadrants are moving equally with respiration. Uh, there were no cough impulses present. Her abdomen was non-tender. There were no organomegaly. There was no palpable lump. There was no free fluid. Dullness started from fifth intercostal space, and liver span was 13 centimeters in mid-clavicular line. Rest of the abdominal examination on percussion was normal, and she had normal bowel sounds. Digital rectal examination was done. Uh, there were no external abnormalities, no sinus fistula, external hemorrhoids or anal tax. Sphincter tone was normal, and fingers were stained with clay-colored stools. There were no uh, deposits which were felt.
Okay, okay.
This
Before
was
this, can you again summarize your history and examination?
the 39-year-old female uh, presented with obstructive jaundice with clay-colored stool, high colored urine, and pruritus with no features, which was painless, and there were no features of cholangitis. And clinically, she has good performance status, and she has got icterus.
Okay, move, go ahead.
Her abdominal examination was normal, and there were no evidence of any lump or ascites. And the systemic examination didn't reveal any features of metastasis or
So
yes, sir.
summarization, I'm just like suggesting summarization is very, very important. Before going to examiner, you should always and always summarize your history and examination findings, and you should be prepared for this. Because those are the test points, and that should come immediately in just one or two sentences. Like a 39-year-old female presenting with history of jaundice, 3 months history of jaundice, obstructive jaundice with pruritus, with unquantified weight loss and history of cholecystectomy uneventful 6 months back.
पीछे करो सर
And
पीछे
on examination, apart from jaundice, there is
करना
no
है
other
तुझे
significant findings. Please mute other joinees, please mute your mobile. So that is very important. Okay. So you should always prepare your summary and So with summary again, is there any change in your diagnosis or it is the same?
Sir, I'll put down hilar cholangiocarcinoma further down because the liver examination was normal. Usually, with hilar cholangiocarcinoma, there could be palpable liver. It's not there.
And is it not there with other obstructive jaundices, malignant jaundices like pariampullary or head of pancreas? Is it not there?
Yes, sir, it is.
So is it the finding which rules out hilar cholangiocarcinoma?
No.
Okay. Um, so anyone else, if you want to ask anything from Shikhar?
You please go ahead. Yeah.
Okay.
So what you want to do next?
Sir, I like to investigate the patient first to confirm my diagnosis and then to assess the general condition of the patient and uh, investigate for pre-operative fitness also.
No,
Till
why the
now, we
second
have
part?
not,
You are not even diagnosed, no?
till now
Why you want
diagnosis
to
is
tell
not clear.
pre-op fitness?
Yes, sir.
So you want to confirm the diagnosis right now. What investigations you want?
So to confirm my diagnosis, I'll do imaging in the form of ultrasound first, which is extension of
No,
my
again,
name.
please listen. Okay.
Yes, I
Here,
got it.
you are in the super specialty. We don't want philosophical statement, imaging, cross-sectional imaging, all these things. Please tell exactly the You take a form and tick what investigation. You exactly tell the same here. Otherwise, you'll think that we are trying non-specific statements. Okay. Please tell
So
exactly what you want. Okay.
I'll
That
first,
invest
sorry,
once
sir.
that statement should not invite more questions, whether it is this type of that, this type of CT, this type of MR, nothing like that. You please tell what you want to tell. List out these are my investigations to reach a diagnosis, or these I will order simultaneously, or I will order this first and wait for the result, then I will order something else. It has to be very clear. The patient is in front of you. Imagine what exactly you are going to do. You are going to do this simultaneously. Ask the patient, you please do all this. I don't have a diagnosis today. Please get all these things done. Come back to me. Exactly tell what you are going to do, that only here. Then you tell the patient, after this investigation, I will tell you what to do. This is what happens in the clinics. You try to replicate exactly here. So now you tell this patient is in front of you. This history we heard. You made up your mind. This is your differential diagnosis. What you are going to tell that patient, and after you tell that patient is going to get that investigation done and come back to you. You please explain. Yeah.
So I'll ask for a CCT abdomen and I will ask for blood investigations in the form of CBC, LFT, and other biochemical parameters.
Okay, and you'll not ask for ultrasonography for this patient.
I'll ask for ultrasound as well. Yes, sir.
So you are mentioning you are asking for CT scan along with blood investigations.
Ultrasounds, CT scan, and blood investigations.
Can the ultrasound suggest like something on that basis? Your cross-sectional imaging may change.
Yes, sir. If there is a filling defect in the bile duct, then I will ask for
Why not to like go for ultrasonography and then depending on the findings you will ask for cross-sectional imaging, that is whatever is required.
yes, sir.
Okay, so in blood investigations, you named CBC, LFT, KFT, everything. So specifically, you want to see first what LFT.
Sir, in LFT, I'll like to see the level of bilirubin, direct and indirect bilirubin, total protein, albumin, uh, AST, ALT, alkaline phosphatase levels, and uh, coagulogram also, sir, PT, INR.
Okay. So in ultrasound, what all you want to see? Ultrasound.
Sir, in ultrasound, I'd
Specific
like to, sorry, sir.
findings, specific ultrasound findings you want to see.
Sir, the status of liver, any stigmata of chronic liver disease or any spatial occupying lesion, IHBRD, common bile duct dilatation, any mass in the GB fossa, and any lymph nodes, and ascites.
So your diagnosis is on clinical basis, it is obstructive jaundice. So
Yes.
obviously you'll see the liver condition, but to begin with, you should start with like there is a block in CBD. If there is dilatation of CBD and biliary radicals, what is the level of block? First of all, you'll ascertain like is it commented on ultrasonography? What is the level of block? And could they see anything possible mass lesion or something there? Then comes lymph node and then like metastatic diseases and liver everything. So ultrasound do we have here? And blood investigation LFT do we have?
Yes, sir. Sir, her PT was 11 and INR is 100%. Her total bilirubin is 12.92 and conjugated bilirubin is 9.46. Total protein is 6.73 and albumin is 4.11.
No,
So
what you
this
interpret
is
from this? Please tell.
So the patient has got conjugated hyperbilirubinemia and her alkaline phosphatase is raised. So it's an obstructive etiology. There is an obstruction in the bile duct, and at present her synthetic function of the liver is well preserved.
No, you can only assume obstructive jaundice or anything else.
Sir, the level of bilirubin, because it is 12.92, it can, if it is very high, then it can indicate a malignant.
No. These are not absolute questions. Okay. You heard the history of this patient. Okay. What are the history? How many days or weeks?
3 weeks.
3 weeks.
Yes, sir. Yes.
You have some, you had some differential diagnosis. So you know that the liver function test are some indications of etiology of the obstructive jaundice as well. Correct?
Yes.
Please take your differential diagnosis back, compare with this, and tell, okay, I will stick on to this. This is my priority. This is less possible. This is more possible. All these things you have to explain. Or you can tell that I can't change anything. I'm not getting any further information.
Sir, I'm not getting any further information with
A
this.
benign biliary stricture post cholecystectomy was your differential diagnosis.
Yes, sir.
3 weeks, this patient continued to have jaundice. According to you, she is telling that jaundice is increasing, correct?
Yes, sir.
Okay. So this 12.92 is okay. If it is hilar cholangiocarcinoma, total is 3 weeks or 4 weeks?
Sir, 1st of April. So now it is almost 4 weeks. Yes, sir.
Yeah, it is 4 weeks. Okay. Now please tell your hilar cholangiocarcinoma is likely. All this, that is the way to explain. So you don't want to change anything.
No, sir.
Okay, fine. Do we have the ultrasound investigations? So there are, I'll tell you, please go back. So when you have a 13 total bilirubin, nearly 10 conjugated bilirubin, as the bilirubin increases, it's not mandatory that conjugated bilirubin will proportionally increase beyond a point, but it is here. You have a 13 bilirubin total. Your alkaline phosphatase is 308. What is the normal value normally?
120, sir.
Okay.
Yes.
There is some disparity here. These are giving clues, some clues which you should know. Okay. Now please show the ultrasound diagnosis. Ultrasound, please.
So this ultrasound was done outside. It shows liver span of 12.7 centimeters in craniocaudal span. There's bulky head of pancreas with hypoechoic mass causing gross dilatation of CBD and bilateral central and peripheral IHPRD. GB is not visualized. It is post cholecystectomy status.
Comments and diagnosis.
Sorry, sir. Comments. Yes, sir. Sir, with this ultrasound, the pancreatic malignancy is uh, now more probable.
Any other diagnosis you can have?
Uh, Sir, could be chronic pancreatitis, but there was no history of pain.
No. You have a hypoechoic mass here, head of pancreas. Can you have any other diagnosis apart from carcinoma of pancreas?
There can be a
Can it be a lymph node mass?
yes, sir. It can be a lymph node mass. Yes, sir.
It can be a lymph node mass.
Yes, sir.
Okay. So what you want to do next?
Sir, with this finding, I'll go ahead with CCT abdomen, sir.
So I am writing here CCT abdomen. Okay, fine. And sending the patient.
Sir, CCT abdomen pancreatic protocol.
So this was the same question Dr. Ashish asked you. You wanted a CT and ultrasound together that time. What you would have written if you don't know that the head of pancreas has a lesion, or if you know that, so it makes a difference.
Yes.
I say, please never go to whatever the argument is, please never skip the ultrasound. We are not in that stage yet to skip the ultrasound, because even your study protocol of CT, sometimes you may need an MR. It can happen. Okay. So what you want to do next, you want to do a pancreatic protocol CT. That's what you are telling.
Yes, sir.
Any other thing you want to know before that, or you add?
Sir, before doing CT, I'd like to see the RFTs, renal function test.
Already seen, no? Last slide, please show the last slide.
Yes, sir. It's normal, 16 and 0.6.
Show the ultrasound report. So what you want to do next? Any other thing you want to know? So what is your diagnosis now?
At present, diagnosis is carcinoma head of the pancreas.
Is it an aggressive disease?
Yes, sir.
So you don't want to do staging. That's what we assume now. Because the moment you say pancreatic protocol CT, we assume that your staging is done.
No, sir. Sorry, sir.
So what staging you want to do?
CT, chest, abdomen, and
You want to
pelvis.
do just CT.
Yes, sir.
Okay. So do we have the CT?
Sir, this is pancreatic protocols. I'm
How do we know it is pancreatic protocol?
I'm just starting. Yes, sir. Sir, here liver is normal in outline. There is IHBR and sir, we can see the right and left hepatic artery, which seems to be normal. The clips are seen in the GB fossa of the previous surgery, and here in the celiac,
No, which phase of CT are you reading?
this is a arterial phase, sir. The right hepatic artery is normal in its course. It's cannot change.
So ideally, which phase should have been described first?
Sir, venous phase. I'm so this is uh, here also we can see normal outline of liver. There are no metastatic deposits. IHBR. There is intrahepatic biliary radical dilatation, and sorry, sir. So the video is
Who is having control? You have the control? Please show again. Make it full screen, please. Non-moving? Yes.
Sorry, my internet was lost, sir. Sorry.
Oh, okay.
so, we can see, sir, central and peripheral IHBR, intrahepatic biliary radical dilatation, and now we can see the portal vein, which is coursing, and this is the confluence. Here, there is pancreas head, although the mass is not very clearly seen, sir, in this phase. But this is hypodense. There is a
You started with
hypodense.
bilobar IHBR dilatation. You immediately jump to portal
Yes,
vein
sir.
and
No,
right
sorry,
with
sir. And
tracing portal vein.
CBD, CBD is dilated, grossly dilated, and it is, sir, here there is a abrupt cutoff of common bile duct in the, this is the point where there is an abrupt cutoff, sir.
Your bile duct examination is not complete. See, you should know how to go ahead with the CT reading, okay? After ultrasound, your only diagnosis is carcinoma pancreas. So you have some objectives to assess the CT. One is the TNM staging.
Yes, sir.
So when you got the TNM staging, it may be one way is you say the metastasis first, nodal second, tumor third, or tumor nodal exchange. You assume you accept one model and explain. Here we are getting some information about M stage, some information about T stage, no information about N stage. So these are all complicated. Okay. Second, you have to tell the liver status because it's a jaundice patient, the medical aspect of the liver. Third, you should also tell us what is the bile duct involvement. So, for example, there are some clips you have to tell that I don't see any growth there. So, we will interpret that okay, carcinoma gallbladder is less likely. All this
Yes, sir.
interpretation should come. You told biliary dilatation is there till lower end.
Yes, sir.
But there is one more duct is there. You never mentioned about that. Your diagnosis. We are concerned with pancreas now because you ultrasound showing pancreas. Information about pancreas has not come yet. Okay. The organ of
Yes.
origin is pancreas. That has not yet come. So all these you should have a mental checklist of how to exercise. So please explain all this in this CT quickly. Because despite examining the CT 10, almost 9 to 10 minutes, still we are not able to assess the TNM stage.
Sir, there is no, the liver is normal, and there is no deposit or any space occupying lesion in the liver, and there is no ascites. Sir, there are no obvious lymph nodes, pericholedocal, the pancreatic lymph nodes are not seen, sir. So there is no mass in the gallbladder fossa, or
This is what triple phase CT scan.
yes, sir.
And you are reading this which phase are you reading?
Sir, venous phase.
Venous phase. To assess the pancreatic parenchyma, venous phase, is it the good phase to see the pancreatic head mass
No, sir.
and pancreatic parenchyma?
No, sir.
So what is the good phase to see the pancreatic parenchyma?
Panc Pancreatic phase, sir. 40 to early pancreatic, early artery, 40 to 50 seconds after injecting the dye.
Do you think triple phase CT and pancreatic protocol CTs are same, or you are intermixing it?
No, sir. They are not same, sir, because in pancreatic, in triple phase, the ideal phase is in the normal. It is early venous phase in pancreatic phase, sir. It is 40 to 50 seconds after injecting the dye. That is the time when uh, arterial phase is taken.
what you are telling is the theory. Now, what you ordered was pancreatic protocol. Then you have started explaining it as a triple phase. Now, again, coming back to pancreatic protocol. So stick to one form which you want to order and then explain according to it.
Yes, sir. So here we can see a pancreatic head mass. This is hypodense.
So these all things should come very smoothly, and there should not be much questions in reading CT scans and everything, so that discussion can move forward to in more
Yes.
details and like patient management details of like all those things. So reading CT scan should not be like very problematic for all, and it should finish very fast. Like to start with the metastat you see for M, then you like have started reading dilated IHBR, then trace it down to the level of block. Then surrounding you see there's a mass lesion there in the head of pancreas, and then surrounding structures what are involved with this mass, locally described as that mass. Then come to the nodal status and pancreatic duct. Obviously, you have not mentioned you never mentioned about pancreatic duct. How is it looking in the CT scan? That sir gave hint of.
Yes, sir. The pancreatic duct is seen, sir, when pancreatic duct is dilated, sir.
Is it dilated?
Yes, sir.
From
Is it
here,
dilated here?
Please look at this CT again in the intra-aortocaval area. Did you see it?
If somebody asks to see the interaortic area, should you see it in arterial phase? Will you be able to see the IVC there?
Sorry, sir. This is yes.
Go down.
So these areas are important. Right? So you should tell all these things because the head of pan. Okay. What you want to do next now? What is your diagnosis after CT?
So in CT, there is a hypointense mass in the head of the pancreas, and SMA, SMV are away from the tumor, although the portal vein is in close proximity, but it is not involved by the tumor. So this is a resectable pancreatic head cancer.
What you want to do next?
Sir, I'll work up the patient for surgery, sir, upfront surgery.
Mhm. Have you asked for CA 19.9 in this patient? Does this have any role in management or decision making?
CA 19.9 has an important role, sir, but because patient is
Because patient is
having jaundice at present, so there can be a probability of fallaciously high reading. Therefore, I have not mentioned CA 19.9 at present.
so
But
that
if I intended to do a drainage procedure, then I would have done a CA 19.9 and then followed it up with after drainage to see whether there is a decrease in CA99 values or it remains high after normalization of bilirubin.
Now, what you are trying to tell is in obstructive jaundice, suspected cancer, carcinoma of pancreas, CA99 has no role. This is what you are trying to tell us, correct?
No, it has got a role, sir.
What is the role?
Sir, first it gives a baseline. Second, if it is very high, then it is indicative of malignancy, and it is if it also gives functional status of the patient, biological status of the disease. So, if it is more than 500, for example, it will still be a
No,
borderline.
no. Please talk about only patient with obstructive jaundice. Please specify what is the role of CA99. In suspected carcinoma of pancreas, obstructive jaundice, currently the patient has jaundice. Please tell what is the role. Will you get it or not?
I'll get it, sir.
Why?
So, because it will give me the baseline of CA99 levels.
Baseline, you are told jaundice patient will be more, no?
It
So
will
you
be
will
a
not get
fallacious value. We will have to, yes, sir. Sir, if we are taking up this patient for upfront surgery, then after surgery, the CA99 value should come down. And also
So,
during follow-up, it will be a important marker of
so you
recurrence.
please answer my question. Can you get any patient with a normal CA99 when that patient has obstructive jaundice?
It can happen in 10% of the cases where,
So it can happen.
yes, sir.
Fine. So does it mean that all patients with carcinoma pancreas obstructive jaundice will have high CA99?
No, sir.
No. Now, if it is a high CA99, which level of jaundice, normally CA99 may not be that reliable, which level of CA99 and jaundice it will still reliable? Let us say CA99 is 2000. Have you seen such patients?
Yes, sir.
Have you seen 8000 CA99? Can it happen due to obstructive jaundice?
No, sir.
What is it interact? So this is what I said. So before start taking the blanket statement, be clear what you're talking. Bilirubin level has some false positivity, but that doesn't mean that it is applying to all 100 patients. Okay, it's
Yes.
different. Okay. What else you want to do? Let us say this CN, you want CN99. Do we have CN99 value?
No, sir, we have not got the values at
Okay,
present.
let us say it is 8000. Now, what you're going to do?
Sir, if the CA99 values are 8000, then I'll go for drainage procedure. I will ask for ERCP and stenting. I will ask the patient to go into prehabilitation program, and then I'll refer the patient to oncologist for neoadjuvant chemotherapy after the bilirubin levels are less than 3. And also, I'll like to rule out metastasis because the levels are so high. I'll ask for FDG PET scans.
So don't you want to see the value after drainage? You'll straightforward, like from here only you've decided you'll do all these things. You'll send this patient for neoadjuvant, you'll work up for the metastasis. You want to, after drainage, don't you want to see the CA 19.9 again?
Yes, sir. Again, I'll like to reevaluate the CA99 values. Yes.
So do we
Okay.
have CA99? No.
No.
So far, sorry, sir. I have
Oh,
not.
not done. Okay, okay. Fine. So what is your plan in this patient?
Sir, at
Let
present,
us say CA99 is 400. What is the plan?
so if CA99 is 400, I'll start the patient, prepare the patient for surgery. Meanwhile, I'll ask her to go into a prehabilitation program, build her up nutritionally, ask her for physiotherapy, and we'll go ahead with upfront surgery.
Are you sure?
So how long will you take for rehabilitation? Patient is absolutely fit to like this patient is operable. How
This
long would
patient
you
is
wait?
operable. Her functional status is also good. ECOG status is 0. So we
So
will
what is the role
operate
of
her as soon as
rehabilitation?
possible. Yes, sir.
Now, please tell the components of rehabilitation
So in
in
pre-rehabilitation,
this patient.
sir, nutritional and physiotherapy.
How long? What is your nutritional duration for rehabilitation?
Sir, 3 weeks.
So you want to give nutritional rehabilitation for 3 weeks for this patient before
No,
surgery.
sir.
So that's what you told. No, we are not asking theory. Please tell. The question was what you want to do for this patient.
We want to do
You want to
upfront
do
surgery.
surgery. You want to do rehabilitation. What is the danger of putting rehabilitation program to this patient?
It will unnecessarily delay surgeries.
What is the problem of delay?
There can be a disease progression in.
Disease progression you are worried in this patient.
No, sir. Her jaundice can increase. So
So this is what the exact blunder we tell in discussion. See, please apply to this patient. No, so this patient already having bilirubin of 12 to 13,
yes,
11.9 or 12. You know that if you want to operate this patient carcinoma pancreas with such a mass lesion, you want to operate directly, you have to do it quickly, maybe
yes,
a week or more. Otherwise, it will cross your protocol or whatever limit of the upper limit of bilirubin, patient will end up in cholangitis. So here we don't have time if you put a rehabilitation program. So your idea is good, but that is wrongly applied here. Because in no rehabilitation program is a crash course. 2 days, 3 days, you can't do anything. Okay. So, but what should be your answer with respect to that question? Are we sure that this patient can undergo surgery directly? Is he nutritionally fit?
the nutritional assessment.
So whatever available, can we go ahead directly?
Sir, her performance status is good. Her albumin levels are good, and there are no signs of any deficiency. And the disease is of short duration. She has got good appetite. We can go ahead with
Please
surgery.
go to the investigation once again. Blood test. Are you okay?
Yes, sir.
Okay. So TLC is okay for okay, fine. So PTINR is also okay. You go ahead. That's what you're telling, no? So this is what it is. Okay. The moment, what is the TLC now here?
8,900
No, total leukocyte count.
is 8,960, sir. Yes, sir.
So it's not low. Okay.
Yes, sir.
So the patient can develop cholangitis anytime. So if you want to intervene, you have to do it quickly. Get a CN antenna and proceed with surgery.
Yes, sir.
Yeah, Dr. Ashish and Dr. Guru. Yeah, please go ahead.
So with the CT findings, where would you keep this patient like resectable, borderline resectable, or locally advanced? And what criteria would you use for this?
Sir, NCCN gives guidelines for resectable, borderline resectable, and locally advanced cancer. So, for head, body, and tail of pancreas. So, in head of
So
the
here it is head of the pancreas. We are talking about head. So
yes,
what
sir.
are the criteria and where does this patient fit in?
Sir, in head of the pancreas, resectable disease will be when the tumor is confined to the pancreas and it is not involving common hepatic artery, celiac artery,
Common hepatic artery is involved in head of the pancreas.
a tumor in if it is
Where do you find common hepatic artery involvement?
sir, usually in the body of the pancreas,
Neck.
neck. Yes, sir.
Okay. So for this patient, it seems like vessels are okay and contact with the SM like portal vein is less than or
Less
it's
than
in fact like
180 degree. Yes, sir.
most likely. So it is a resectable disease.
Yes, sir.
Okay. So do you know some recent trials about resectable disease advantages of neoadjuvant therapy?
Sir, in borderline resectable
No,
cancers,
no, not borderline. Resectable, see ahead of pancreas. A role of neoadjuvant chemotherapy.
no, sir, I'm not aware.
Okay. Venous involvement. What is like classification or grading of venous involvement? And what is the name of that classification? Do you know?
So, Japanese, they classify venous and arterial involvement of pancreas. But
E-
in NCCN, the borderline resectable will be abutment of
No, no, I'm not talking about this. I'm talking like what is Ishikawa classification of venous involvement?
sir, I'm not aware. Sorry, sir.
Okay. So
Okay.
you'll go ahead with what
Uh,
procedure in this patient?
Sir, in this patient, we will go ahead with uh, pancreatic or duodenectomy, sir.
Okay.
It can be laparoscopic and open.
Okay. So for
Or
this patient, a classical pancreaticoduodenectomy or a pylorus preserving pancreaticoduodenectomy?
sir, we'll go for pylorus preserving pancreatic or duodenectomy.
For such a big head mass. Where don't you consider pylorus preserving pancreaticoduodenectomy as an adequate procedure and you go for Whipple's?
Sir, sorry, I didn't understand your question. Sorry, sir.
So logically, complications wise, it is proven that both are equally good and there is
Yes,
no difference.
no difference.
But there would be situations where you do not opt for pylorus preserving pancreaticoduodenectomies and you go for classical pancreaticoduodenectomy. What are those conditions?
Sir, if the mass is there is a large mass which is involving D1, so in that case, pylorus preserving will not be suitable. Uh, and also in Whipple's in laparoscopic Whipple's uh, pylorus preservation will be if there is a bulky mass, then it will be a difficult thing. Yes.
So you told like in laparoscopic people, what is this concept? We don't know like pylorus preservation will not be possible in laparoscopic people.
If the head mass is bulky, yes.
That is true with the open as well. If there is a
Yes,
large
sir.
head mass, there is a large distal cholangioCA for which you are operating. D1 is at rest. Probably you will not go for. So for this big mass, probably you will go for a classical Whipple.
Yes, sir.
Sir, you want to ask anything?
Now we can
why?
invite questions from others. It is 1 hour now. So anybody, any other faculty or give some comments, or anybody want to ask questions also fine.
Biju, I think there is a question: interaction of bilirubin and CA 19.9. Is there a cutoff bilirubin level after which CA 99 level will not be affected? Would you like to take?
No, it's not a cutoff. Basically, what happens, we put 35, 36, 37 as the normal cutoff for identifying a negative, it's a negative predictive value.
Yeah.
Okay, you say it is not there. So in jaundice patients, what happens? In order to create a negative predictive value, the baseline bilirubin will be more. That is what it happens. So people study whether 100 is a best cutoff, 120 is the best cutoff. So it is trying to create a negative predictive value. Okay. Now there are several studies, but as of today, we can't tell an exact cutoff below which we can say it's not a metastatic pancreatic cancer. That we cannot tell. Okay. But what we observe in clinical practice, very high, what we call super high levels of CA99 is still suggestive of advanced pancreatic cancer despite the level of bilirubin.
Yes.
Yes, so that is what my comment.
So I think message was you should interpret CA99 level in patient with jaundice carefully. But even in patient with jaundice, if it is strongly high, severely high, then it is still a diagnostic indicator of this thing, advanced malignancy. Then it should be better to interpret levels after the biliary decompression in patient with high bilirubin. That's what I think the message was.
Thanks.
I think today's session for Dr. Pithius, there would have been so many messages. First, according to me, was your uh, should not be reading between the line. It is clearly math. Whatever is available, and you interpret that only. If there was no history suggestive of on the history point, there is no suggestion ki it is pariampullary cholangiocarcinoma, gallbladder cancer, but we were still making that only on the basis of history. And after examination, also in a patient who has already had cholecystectomy, there is no hepatomegaly, there was very difficult to diagnose these things. And then you again, when Dr. Ashish asked, you are saying you will order both ultrasound and this thing CT scan simultaneously. We might do in practice in OPD because patient may we don't want patient to run here and there for we will order one ultrasound and again write CT scan, that will waste time. But ideally as a screening investigation, then that will guide. In some patient you may not be able even want to do this thing CCT and all. You can directly go to PET CT if you are planning for chemotherapy and all. And in some patient you may would like to do this thing MRI or MRCP. So it is an screening investigation. Dr. Biju and Dr. Ashish and Dr. Kunal have pointed out. I think it is a good learning experience for all. Resident joined, and next session will be on 6th May. Case presentation by GV Pant Hospital, and moderators will be Dr. Ajnish and Dr. Rajesh Panwar and Dr. Tonal Bharti. Dr. Biju, you want to make any comment? And
Anybody want to ask anything? Any resident want to clarify anything? No, I have no further comments.
So usually what happens when case presentation, just in history, every candidate loses his like complete time, history and examination. Discussion doesn't move forward. So after like evaluating your patient, you should always and always give some 5 minutes with the history and examination, clarify things, make a good summary, and then come with like specific questions. And there should be a fluency. You should not stop and take too much of time presenting very simple things. Then the discussion can move forward. Otherwise, you'll be stuck in examination in 15 minutes time. Like in 1 hour, we could not move even further. So
You're
15
right.
minutes. So after taking history and examination, you should evaluate your history examination, make a good summary, and prepare yourself. What can be the
Yes.
questions? What is the likelihood of this patient? And with every, like, there have been too many presentations, and you know that in obstructive jaundice, these are the set pattern of questions from where every examiner starts with.
The
You
thing
should
is,
always.
everyone stuck with the diagnosis. You know the diagnosis, and then your mind is blocked, and every time whatever you do, you reach to that diagnosis only. So always try to get into that trap.
So I
I think
will put one point one to explain. See what we are telling, Dr. Ashish also. Please understand that the time you spend on clinical history and examination more in the examination is inviting more and more trouble. The reason is this is a highly subjective area. Okay. The moment you start discussing about investigations, then we are going to highly objective area. Okay. In the subjective area, examiners may have their own version. You are giving enough scope while you drag the history and examination. So entire subjective interpretation is going to come. It may contradict your finding, your interpretation. So your job is how to safely navigate the subjective area, which is the history and examination, and quickly land into the objective area where you can express your knowledge and there won't be much controversy. You start examining a CT, examiners and your pattern examination might be same. So how to restrict to 5 to 7 to 10 minutes maximum clinical history and examination is a job, as Dr. Kunal told, you have to be pre-prepared for that. Because 90% of the time it is the same questions repeated. How to navigate and reach to the investigation stage, which objective is the strategy you have to employ. Yeah. Okay, that's all from my side.
I think thanks Dr. Biju and Dr. Kulal, Dr. Ashish, Dr. Biju and Dr. Kulal had stepped in for Dr. Nihar and Dr. Utpal as both were not unable to join today. I think we can close here now. Thanks a lot, everybody, for joining.
Thank you, sir.
Thank you.
Thank you.